Okay, we're going to start Chapter 7, which is Dental X-ray Film. The learning objectives for this chapter are to define the terms associated with dental X-ray film, discuss why the radiographer should be familiar with dental X-ray film, describe film composition and latent image formation, list the different types of X-ray film used in dentistry, define intraoral film, and describe intraoral film packaging. We need to identify the types and sizes of intraoral film available. We'll discuss film speed, define extraoral film, and describe extraoral film packaging, discuss the differences between intraoral film and extraoral film, and identify the types of extraoral film available. And we'll describe the difference between screen and non-screen films. And lastly, we're going to describe the use of intensifying screens and cassettes, describe duplicating film, and we're going to discuss proper film storage and protection. Okay, so what's the point of Chapter 7 then? We need to define film composition, we need to detail latent image formation, we need to describe the types of intraoral, extraoral, and duplicating film, and we need to discuss film storage and protection. I totally understand if you're thinking, why do we need to learn about film when everyone's using digital? I absolutely understand that. However, there are some offices that are still using film, and a lot of people in the dental community are very comfortable using film. And it's important that you understand the terminology and you understand the uses of things like that so that you can be on that same playing field with them. Also, you're going to take your boards, and it's definitely going to show up on your boards. Okay, so dental X-ray film composition and latent image. Dental X-ray film serves as a recording medium or image receptor. There is an image, which is a picture or likeness of an object, and then there is a receptor, something that responds to a stimulus. So in every image on every film, there is the image, and then there's the receptor that captures the image, right? The latent image is the invisible pattern of stored energy on the exposed film that cannot be seen. It's not until we develop the film we're able to see the image. So just remember that for later. All right, so what is the film made of? It's four basic parts. There is the film base, there's adhesive layer, there's emulsion, and then there's the protective layer. We're going to get into each one of these. So first we have the film base. It is a 0.2 millimeter thick piece of polyester plastic. It's going to provide all of the strength and the stability for this very delicate emulsion. Emulsion would just fall apart if we were to try to not use some type of stable support system. The film is transparent and it exhibits a slight blue tint that is used to emphasize contrast and enhance image quality. All right, so then the adhesive layer does probably exactly what it sounds like it does. It attaches this emulsion to the base. The adhesive layer covers both sides of the film base on the upper and the bottom, and it's added to the film before the emulsion is applied. All right, so I changed the theme on this. Looks like I should have adjusted the pictures. Anyway, film emulsion is a homogeneous coating with a mixture of gelatin and silver halide crystals attached to both sides of the film base. It's made up of gelatin, which is used to suspend and disperse millions of microscopic silver halide crystals over the film base, and it's made out of those halide crystals, which are silver halide crystals that absorb radiation during exposure and they store the energy. Why are there two emulsion layers on intraoral film? This allows an image to be produced using less radiation. And a halide is a chemical compound that is sensitive to radiation or light. And then lastly, there's the protective layer. The protective layer is a thin coating over the emulsion to protect the emulsion from damage. It protects the emulsion surface from manipulation as well as mechanical and processing damage. Okay, So, latent image formation. Silver halide crystals contain various levels of stored energy depending on the density of the objects in the area exposed. The stored energy forms a pattern known as the latent image. The latent image cannot be seen until chemical processing to produce a visible image. For instance, like when the X-ray is passing through the anatomical surfaces and it is part of it is absorbed maybe by tissue or by bone, but some of those X-ray photons do pass through. That means that the energy that reaches the receptor on the other side isn't going to get as much energy as maybe it will in the areas like in between the teeth where there's just air. All right, so this is figure 7-3. It's found on page 62. It's a wonderful visual representation of when that X-ray photon enters into the space, you know, how it knocks off electrons, and so those electrons would be more attracted to the silver in the sensitivity site, and so the atom that's in there is now attracted to the sensitivity site, and so it moves further and closer to the sensitivity site, and then once it does so, it makes the silver a more complete atom. And basically, this is just how all of those atoms interact together inside those silver halide crystals, and it is how the stored latent image is produced. So when photons strike the emulsion, some silver bromide crystals are exposed, but some are not, right? Maybe in areas where there's amalgam. The crystals that are exposed when ionized and the silver and bromide atoms are separated. Irregularities in the lattice constructed of the exposed crystal sensitivity specks attract the silver atoms. These aggregates of neutral silver atoms are known as latent image sensors. An example of another type of latent image is like fingerprint. So when you touch an item, you leave your fingerprint there even though you can't see it. And then when you treat it, you're able to see your fingerprint. Okay, there's three types of dental x-ray film. There's intraoral, extraoral, and duplicating. Okay, so intraoral film is placed inside the mouth, and it's used to examine the teeth and supporting structures with a little bit more detail. So how do skilled dental radiographers reduce the patient's exposure to x-rays? By reducing the number of retakes. Why does the film need to be protected from the light? Light is a form of radiation and will expose and ruin the film. Light cannot pass through the packet, but x-rays can. The terms film and film packet are often used interchangeably and incorrectly. The film is um, the part with the emulsion and the base and the adhesive layer, all of that is what makes up the film. The film is inside the packet. However, a lot of times, if I say film, I mean the whole thing. If I say film packet, I'm talking about when I've separated them all. Okay, so the film packaging is used to protect the film from light and moisture. It's usually available in plastic trays or it comes in cardboard boxes, and it contains 25, 100, or 150 films. The boxes are labeled with the type of film, the film speed, the film size, the number of films per packet, because some film packets have one or some of them have two, and then by one and two, I mean one dental film or two dental films. And then the total number of films enclosed, which is the same thing. And then the expiration date is on there too, because these things do expire. And so what we see here is this outer package. We see the lead foil backing, and then we see this paper wrapping. The dental film sits inside this paper wrapping. It goes kind of underneath it. And so that one side is a little longer. So when you open it and you grab that little paper part, you can pull up on it and it'll actually pull the film out for you. Sometimes with the film where there's two dental films in there, maybe you're going to send one to, an insurance company or to have a referral, or maybe the patient has requested to have the radiographs to take home. And so well, you'll learn later and when we do the legal part, but the radiographs are actually the property of the office. They're not necessarily the property of the person. And so when we take them, we keep these radiographs in the office in our patient's charts, right? But sometimes the patient, maybe they want to go to a different office, or maybe they'd like a second opinion for whatever reason. They want a copy. And so what we do when we take the x-rays, we'll just use the ones where we have two, or if we only have one, we've already taken the x-rays, then we'll use duplicating film, which we'll get into later. All right, I already talked about this one a little bit. There's four components. There's the film, then there's the paper film wrapper, and then there's the lead foil sheet, and then there's an outer package wrapping. Now, light can't pass through this outer package wrapping, but x-rays can. I know that it seems like such a silly thing to say, but you might see that again, so I would remember that one. The packaging also protects the film from moisture and from fingerprints and things like that. Okay, so here we have X-ray film, and it's been kind of cut in half for us to be able to look at it from the inside. And so here we can see this outer protective sleeve, right? I'm going to draw all over this. It's going to be horrible. And then we have this is the lead foil sheet that's in there, protecting the film from backscatter, which we'll talk about when we get there. And then this is that wrapping, the paper wrapping that kind of covers, or it like holds the film. Then this is the film that's inside here. This little guy right here, this is an identification dot. You'll see it on all film, and you'll see it on digital x-ray too, but it's just like a little image on the x-ray. It's like an A, or sometimes it's a different type of letter. Usually it's an A. Anyway, in film, it's a dot, and when you look at it, it needs to be a dot, not a dimple. Okay, that's important for later. That's going to show us, see, if we were to take an image, the dot would show us the correct side of the film. That's the side we want. If we were looking at it and it were a dimple, we would be looking at the back side of that film. And it's very easy to confuse the two, and it's going to look like both of them are right. So I want you to remember that. We want a dot and not a dimple. So it can be double emulsion film is what this is talking about. And it basically just means that emulsion is on both sides of the film, which we talked about when we were looking at how film is made. There's the base and then there's emulsion on both sides. That is because it takes less radiation to get a diagnostic radiograph when there is emulsion on both sides, capturing that energy, than it does if we use single emulsion, like a single side of emulsion. Paper film wrapper. So it's a black protective sheet that covers the film and protects it from light. It also protects it from like sticking to the protective outside layer. It protects it from sticking to the lead foil. It has this really nice, it's all one piece, right? Like we can say there's an inner part and an outer part all we want to. And that's true, there is a part on both sides, but it's connected. So when we open it, you'll see there's like a little flap, and when you pull up on it, it will actually kind of pop your film up out for you because the paper is just like this little U shape and the film sits inside of it. The lead foil. So this is in here and it's behind the film wrapped in a it's behind the film that is wrapped in black protective paper. The shield for the film, I'm sorry, the lead foil is going to shield the film from backscatter or secondary radiation that creates film fog. And we remember that sometimes the X-ray photons go straight, but then sometimes they like hit something else and turn around and go a different direction. And so what we don't want is for our X-ray photons to pass through and get to the receptor, and then suddenly they pass through the receptor and turn around and come back to the receptor, right? And then try to get to our film. So the lead foil is there to protect those X-ray photons that have passed all the way through, the teeth surfaces, they've passed through the airspace, they've passed through the receptor, through the film, which is a good thing, and then they've passed through the receptor and they're continuing forward. What we don't want is for them to turn around and come back. It has a pattern on it. You can see these little bumps all along it, and that pattern is important because sometimes people will put them in backwards. You're having a day, and you are putting your films together really quickly, and or your X-ray armamentarium, and you stick a film in there backwards, and you can see the color, and you're not looking at the blank white side. And then you take the radiograph, you'll be able to tell very quickly that you did that. Let's see. So what would happen if the lead foil was not there? The backscatter radiation would fog the image. So this is an example of what a film would look like if it had been placed in the mouth backwards. Sometimes that word backward can feel a little weird. It's basically what it would look like if the film were flipped over and it were stuck into the film holder, kind of like backward, but flipped. The image would appear lighter, and in some cases, it used to be called a herringbone pattern. You might find that on, late night trivia one night. It would look just like this. All right, so we have the outer package wrapping. This is a soft vinyl or paper that seals the contents and protects them from light and moisture. It has two sides. So there's a tube side, which is all white, and has a raised bump, which corresponds to the identification dot on the X-ray film, which we talked about. That side is the side that faces the tube head during an exposure. So if you're looking down the film holder and you're looking at the film as if you were the tube head, then you would see just a solid white color. The other side is the label side, and it is color coded to identify if there is one or there's two films inside the package, and it is according to film speed. It usually has a flap. I don't know any that don't have, in order to open the film so that you can process it. The information that's printed on the label side of the film packet is in the circle or dot that corresponds to the raised identification dot on the film. The statement opposite side towards tube, the manufacturer's name, the film speed, and the number of films enclosed. Okay, so now we're going to get into the different types of intraoral films. There is a periapical film, a bite wing film, and an occlusal film. So the periapical film is used to examine the entire tooth and the supporting bone. The term periapical is derived from the Greek word which means around, and the Latin word apex, which refers to the terminal end of the tooth root. So when we are talking about periapical, we mean this space around this being the apex of the tooth, and this around it, that's what we're looking at. This type of film shows the tip of the tooth root and surrounding structures, as well as the crown. It's important that we don't forget that we still have to get the crown of the tooth. We can't cut that off, and it wouldn't be a diagnostic image if we cut off the top of the tooth. But this area here, it's not a diagnostic image if we take it and we can't see any of this space down here. We have to see this area around. You should shoot for maybe 2 or 3 millimeters of bone around and underneath these periapical, or the apexes of these roots. All right, so bite wing film. This is named because of this little wing that we see over here in this image. Because of this little wing, that is the part where the patient bites onto, and that's what's going to hold this film still inside the mouth in order for the image to be taken. So that's why it's called that, bite wing. The bite wing is used to examine the crowns of both maxillary teeth and mandibular teeth on one film. It can be used for, it's mostly used for examining the interproximal spaces in between teeth. So this is what the dentist uses to look for cavities. It's the best type of radiograph to look for cavities, and it's also the best radiograph to look for when we're looking at bone loss. This area right here, this is bone loss. This is bone loss. This is bone loss. This is bone loss. Oh, I wish I hadn't drawn on that. Hold on. Let me erase that one. And this area, you can see here, this little guy, that is calculus. And so these are all things we're going to get to know as we move through this course. And we're going to get very comfortable with seeing these types of things on our radiographs, and we're going to be able to detect this bone loss and cavities. Oh, there's some more calculus right there. Rather. Oh, there's more too. You can tell I'm like obsessed with finding calculus. Anyway, used for examining interproximal spaces, and this has certain types where you can stick on these little stickers onto your sensors or onto your film in order to take bite wings, or you can just use the film holders that are made for you for taking bite wings too. That's not a big deal. All right, and so occlusal film is a larger film used for the examination of large areas of the maxilla or the mandible. This is a very good picture of the entire mandible. You can see this person has wisdom teeth in here. And the reason it's called occlusal is because the patient actually bites right onto the film. And that's why it's called that, occlusal, meaning occlude onto the film. And you can see this entire surface. This is a wonderful picture for a radiograph for detecting if a patient is maybe missing a tooth, or um, that's probably the only thing I would use it for. Um, we wouldn't want to use this to detect cavities, right? We're not going to be able to get a very good diagnostic image as to whether a patient has bone loss or cavities from this type of radiograph. All right, so this is a wonderful diagnostic, I'm sorry, a wonderful display for the different sizes of these films. In your book, it's on page 66. It's figure 7-13. And these are actually the life size in your book, not the image you're seeing on the screen. Anyway, in your book, this is the actual size for all of the sizes of film. And so you can see here that there's 5 sizes from 0 to 4. And you use different sizes for the different types of radiographs that you're going to take, and I'm sure you could see why. Okay, so for periapical, you would use a 0, right? For very small children, you definitely not be able to get a, a size 2 or a 3 or a 4 in there, standing up, right? Trying to get the roots of those teeth. You would use a 1 for anterior teeth in adults. I've seen sometimes using a 1 on children when you want to get a posterior 1, but that's not very often. And then 2 is the standard film used for anterior and posterior teeth in adults. Okay, so yes, using a 1 on anterior teeth is also common. Using a 2 is the standard for all teeth on an adult. That'll be on your boards. So for periapical teeth, for adults, anterior and posterior, we're using a size 2. For bite wing film, again, you're using a 0 when you are working with really small kiddos. I've seen using a size 1. Some offices only have a 1 or a 2 size, and so use the smallest size you can in order to make it as comfortable for your patient as possible. If you have all of them, then yes, I would probably choose a 0 for the kiddos. And you would use a size 2 for posterior on older children or adults. As soon as they have a second molar, you have to use a size 2. They have enough room in there. I know it can be uncomfortable, but they can make a size 2 work. A size 3 is longer and it's more narrow than a size 2. It's used only for bite wings. It's only for bite wings. A size 3. It's only for bite wings. Currently, it's not recommended because all of the contacts cannot be opened in one film. Um, so if you were using a size 3, you can see how it's longer. It would actually be able to capture from the molars all the way to the distal thirds of your canines, but you wouldn't be able to open all the contacts in one film. It's not a good idea. I mean, maybe if they had a lot of spaces in between their teeth, but you wouldn't do it. Anyway, a size 3, you would use it only for bite wings. Anyway. Okay, so a size 4 is used to examine large areas of the maxilla or the mandible. It's almost 4 times the size of the standard size 2 film. You can see here, it is a very large film, right? There is no way you're getting a patient to put that whole thing in there and close around it, right? That's why you just go in as far as you can and then close on it. The understanding of the occlusal film, that you use it in order to examine large areas of the maxilla or the mandible at the all at once, that is possibly on your boards. We're going to talk about occlusal films and like the technique of taking an occlusal film later, but I just want you to be aware that it exists. Okay, so now we're going to get into film speed. Film speed. This is the amount of radiation required in order to produce a radiograph of a standard density. It's determined by the size of the silver halide crystals, the thickness of the emulsion, the presence of special radiosensitive dyes, and a fast film requires less radiation exposure. Okay, so if it is a fast film, it needs less radiation exposure. But what happens is the size of the silver halide crystals will determine the speed, or the speed size, right? So if you have large silver halide crystals, then they are going to absorb that energy easier, and it'll be faster. It'll be a faster film. But if it's very large silver crystals, that means you're not going to have as much detail on your radiographs as you would want. And so if you look on page 66, there's a really wonderful little guide here. It says faster films creates images that are less sharp due to large crystal size. Fast equals less equals large. Okay, so the different intraoral film speeds. They come in a range of speed from A, which is the slowest, to F, which is the fastest. It has D speed, EF speed, which is a combination of E and F, and F speed, which are used for intraoral radiography. The use of F speed film results in less radiation exposure for the patient. F speed film reduces radiation dose to the patient, but also provides stable contrast characteristics under various processing conditions. This is important to remember, that any faster than F would be good, right? But we may not get a very diagnostic image. And so we have to find this balance between how much can we reduce the radiation to our patients to how diagnostic our image is. And so the American Dental Association and the American Academy of Oral and Maxillofacial Radiology currently recommend F speed as the standard. F speed is actually only 60% of the exposure time of D speed, which I thought was funny. Like, who's sitting around like, they don't want to say it's 40% less radiation. They want to say it's only 60% of the exposure time. I don't know. I don't know who's coming up with these kinds of things. Anyway, F speed is faster than D speed because the larger crystals and the increased amount of silver bromide in the emulsion. All right, moving on to extraoral film. So these are placed outside of the mouth during an exposure. They're used to examine large areas of teeth and jaws, like the panoramic film, which looks at a wide view of upper and lower jaws, and the cephalometric film, which looks at bony and soft tissue areas in a profile or from the side. Extraoral films are more common in specialty practices like orthodontic, pediatric, and oral surgery practices. Orthodontists commonly use cephalometric films to view the relationship of the jaw to the skull. They're also looking at that profile of the individual. They might want to maybe move teeth around in order to change that profile. Pediatric dentists use panoramic films to see the developing teeth because it's difficult for a child to sit through a full mouth series, and because it exposes the child to less radiation than a full mouth series would. All right, and here are those images. So that top one right there is a panoramic. And so we will actually be taking some of these in our program. And the bottom picture here is a cephalometric. Can you see here how an orthodontist might look to see where this soft tissue sits in relation to the skull? Because if we change the bones, maybe the patient has jaw surgery and they move that jaw forward, then maybe they wouldn't have the same sort of profile, and it would change the soft tissue outer appearance of that patient as well. Okay, so extraoral film packaging. They usually come in a box of about 50 to 100 films. They are not enclosed in moisture-proof packs. Why are they not enclosed in moisture-proof packs? because they don't go in the patient's mouth. They come in either a 5 by 7 inch or an 8 by 10 inch sizes. And then for the, which those are for the cephalometric, by the way, the 5 by 12 inch or the 6 by 12 inch sizes for the panoramic films. And let's see, where should extraoral films be stored? Extraoral films should be stored in a dark room. This prevents them from being accidentally opened in a lighted room, and which would expose them and ruin all the film. You do not want to be the one who opens this box out in the middle of everything and tries to get a film out, because it would ruin the entire box. Like that would be your last mistake. It is advisable to seal an opened box with a rubber band to ensure that the cover doesn't accidentally fall off and ruin the box of film. Labels on the box of extraoral film include information like the type of film, the film size, the total number of films enclosed, and again, that expiration date, because films expire. Okay, so there are two types of extraoral films. There are screen films and non-screen films. Okay, so screen film requires the use of a screen in a cassette with phosphors for exposure. The film is sensitive to fluorescent light rather than direct exposure to X radiation. So please remember that. Screen film is sensitive to fluorescent light. Some screen films are sensitive to blue light and some are sensitive to green light, and that's important, that the film screens match the type of the type of units that you're using, but all of that usually gets figured out dependent on the dentist who orders these things. So then here you can see there's the plastic cassette, the screen base, there's an intensifying screen, and then there's the screen, and then the screen film, sorry, and then there's another screen base, and then the metal cassette back. Okay, so non-screen film, it doesn't use a screen. Go figure. And it's exposed directly to X-rays. It means it's sensitive to X-rays, not fluorescent light. It's actually not recommended in dental use because it requires too much radiation in order for the film to be exposed properly. And so it's much safer to just use a screen film. Okay, so when you're using screen film, you're going to need some things like intensifying screens and cassettes. An intensifying screen is a device that transfers X-ray energy into visible light. The visible light then exposes the screen film. This lowers the radiation dose to the patient. National Board question. Hint, hint. A screen film is secured in a cassette between two intensifying screens of matching size. The intensifying screen is a smooth plastic sheet coated with minute fluorescent crystals known as phosphors. There is a slight loss of image detail as a result of the intensified X-ray beam because the light produces a halo effect at the edge of the image field. This loss of detail makes panoramic X-rays unsuitable for caries diagnosis. For this reason, pediatric dentists take bite wings in conjunction with the panoramic X-ray in order to make a pediatric full set. All right, and here's what those intensifying screens look like. There's two kinds. They're calcium tungstate screens, which have phosphors that emit blue light, and the rare earth screens, which have phosphors that emit green light. That you might see that again. So the calcium tungstate have phosphors that emit blue light, and the rare earth screens have phosphors that emit green light. Require less radiation than calcium tungstate screens. Okay, so rare earth screens would be better. You can see here how there's the base, phosphor coat, the film, the phosphor coat, and the base. You can see what a cassette would look like too. This is another one. We're going to talk about this in the next slide too. A cassette is used to hold the film and the intensifying screens. It can be flexible or rigid. Most of them are rigid, except for the panoramic cassette, which is usually flexible. The cassette must be light tight, which means it's not air sealed, but it doesn't let any light in. And then hold the intensifying screen in contact with the film. Otherwise, the lack of contact between film and cassette will result in a lack of sharpness on the image in that area. You might see that one again too. So they have to be touching. They have to be in tight contact. Otherwise, it'll lose a lack of sharpness of the image in that area. A rigid cassette is usually more expensive too, but it lasts a lot longer than a flexible one does. And here's some pictures of those. You see the rigid one, which we already saw a picture of, and then the one on the right is that flexible cassette. A rigid cassette has a plastic front cover to allow the photons to pass through. The back cover is metal and it reduces scatter radiation. The cassette is marked with an L or an R for orientation. Typically, the cassette is marked, like with this flexible one, the cassette could be marked, or the not the film itself, but sometimes like one of the things inside is marked with that L or R. So you might not necessarily see it printed right on the outside of the box. The front of the cassette must always face the patient during exposure. There's no identification dot on this one, so you have to actually use those L and R's. All right, so moving on, we have duplicating film. This is a very special type of film. It's different from our normal film because it's used only to make copies. The longer that our film is exposed, the lighter the film will get, and it's good for referrals and for the submission of insurance claims. It has emulsion on only one side, and it's not exposed to x-rays, so it must be used with a film duplicator. It's a very special film. It's required to make a duplicate. A duplicate, it's easy. It's a copy. If we need to make a copy of the radiograph, then we would use duplicating film and a duplicator. Duplicating film comes in periapical sizes usually, and the 5 by 12 and 6 by 12 inch, and the 8 by 10 inch sheets, typically in boxes of 50 sheets. It's important to remember that duplicating film never gets exposed to radiographs. It's only ever exposed to light, and that is how we make a copy of a film we already took of the patient, and now we're just creating it on a new piece of film. All right, so film is negatively affected by heat, humidity, and radiation, of course. Film should be kept in a cool, dry place, and it's important to remember that film has an expiration date because those crystals aren't going to stay in that, uh, solution in that balanced state forever. Eventually, they're going to shift or move, and then the radiograph that we take won't be diagnostic, and then we will have exposed our patient unnecessarily, and that would be very bad. And so every film has an expiration date, which is found on the box of where you got the film. So they all have a shelf life. If you look at page 69, you'll find all of the humidity and temperature. These are very important. I want you to take a look at these before you take your quiz. All right, and that wraps up chapter 7. So if you have questions, please put them in the discussion board, and have a good day.